Yeah, so we will recover time during coffee. So we'll have slightly shorter coffee break. But next up, we have Haoran Zhang, who is from MIT. He's a graduate student there, advised by Marza Gassemi. And he has worked on a large variety of things, but today he'll be speaking about group fairness in chest X-ray diagnosis, CXR, and is it helpful or harmful? So Haoran, you have the floor, and I see you have your screen shared.
Great. Thank you very much for the introduction, Daniel, and thank you for the invitation to speak here today. I'll be talking a bit about group fairness in chest X-ray diagnostic models. So first, before we begin, perhaps it's useful to define what algorithmic fairness means. So typically in algorithmic fairness, we're concerned with some quantitative property of a machine learning model. But it's important to keep in mind that there's many other things outside of the machine learning model that's part of your model pipeline. For example, you might have downstream considerations. If your model is deployed in a clinic or a hospital and it interfaces with some clinician, there could be biases introduced with the clinician's input that results in a biased diagnosis or treatment. And just as important, you might have biases in some upstream considerations. For example, you might have a case where the distribution of data that you have during training is not the same as the distribution of data that you have during deployment. And this might manifest itself, for example, in the form of selection bias, where you have different ratios of different populations being integrated into your data, for example, as a result of healthcare inequality due to healthcare access. You might also have label bias, where different groups have corrupted labels at different probabilities, and I'll talk more about this towards the end of the talk. But the summary here is that just because we have an algorithmically fair model does not mean that we have a socially equitable model or a socially good model. There's many other factors that you should consider, and so keep this in mind as we go through the rest of the talk, all the things that algorithmic fairness does not cover. So first, what is algorithmic fairness? Well, there's no unified definition of fairness in the literature, and in fact, there are many, many definitions of fairness out there. One such definition is group fairness, which was covered in the introduction, but there are many other fairness definitions as well. One of which is minimax Pareto fairness, which we'll talk about more at the end of the talk. There's also definitions like subgroup fairness and individual fairness. And if you know the causal graph, you can take advantage of the causal structure, and there's many other causal definitions of fairness. But for the purposes of this talk, I'll be focusing on these two definitions, but it's not to create any false dichotomy. There's many other fairness definitions out there. Choose your favorite or whatever one fits your setting the best. Okay, so let's delve into group fairness in chest X-ray classification. So this was covered in the introduction, so I'll go fairly quickly here. We're dealing with a binary classification problem, so Y is either 0 or 1. And typically, group fairness is defined as some conditional independent statement with respect to your prediction and the group. For example, we might have equality of opportunity, where we say that your prediction Y hat is independent of the group for the positively labeled samples. Now, if your prediction is binary, these turn out to be very nicely reduced to specific binary classification metrics. For example, equality of opportunity turns out to be saying that we have equal TPR, true positive rate, between groups. Similarly, predicted parity says we should have equal precision between groups. And so this is a pretty big assumption because typically our model outputs a risk score between 0 and 1 and not a binarized value. And we'll come back to relax this assumption in a couple of slides. Okay, so first, the question is, are existing X-ray classifiers group fair? And so this is what we studied in our initial medicine paper, which was covered in the introduction, so I'll go fairly quickly through it. But we use Mimic CXR, which has about 300,000 chest X-ray images from a hospital in Boston. We use the Deep CNN to classify no finding. So here, no finding means the absence of any pathology. And specifically, we're interested in the false positive rate. So if you think about it, a false positive for no finding means that we predict someone has no finding when they do have a finding. So that's bad because they could have missed treatments, for example. So we do not want that. And so we examine the false positive rate for each attribute, so for each sex, race, insurance type, so on and so forth. And if you look at the subgroup FPRs, so this is our underdiagnosis metric, we find that we have higher underdiagnosis for females than males, for younger people than older people, for Black patients compared to white patients, and for people who are on Medicaid. And similarly, we can examine the false negative rate, which you might call overdiagnosis. and we find basically the opposite pattern where we have higher overdiagnosis rather for the other groups. Okay, so this is a fairly simple result that was worth a Nature Medicine paper apparently, but how can we dig a bit deeper into this? And so one way to dig deeper is to realize again that your prediction is not a binary value, but it's a probability. So there's a few different ways we can evaluate the probabilistic prediction of a classifier. One way is with calibration. So we said that a model is well calibrated if essentially the probability of a label being 1, given your output being some probability p is equal to p. So another way to phrase it is if I have a model prediction that predicts 35% probability of no finding for a particular sample, roughly 35% of those samples that I predict to be no finding should actually have no finding. So this says if I have a risk score, it should have some actual meaning to it. The probability should have some actual meaning. Okay, and so we can measure how well calibrated a model is with something called the expected calibration error, which I won't go through in detail, but it's a metric basically to calculate how well calibrated your model is. But it's important to note that expected calibration error gap is a strong form of disparity. So if I have a, for example, a perfectly calibrated model for group 1 and a poorly calibrated model for group 2, that means if I deploy a model at 35% threshold, I have 35% operating risk for group 1, but let's say 50% operating risk for group 2. That means I'm implicitly treating group 2 differently than group 1 in terms of the actual risk threshold. So this is a very strong form of disparity that's not being very well studied in literature, but I think it's an interesting area of future work. And so we really want low ECE gap between the groups and also low calibration error general for other groups. And this is related to the idea of sufficiency, which is very similar, except that they have a equal calibration curve, which I won't go through in a lot of detail. Okay, so now that we have a risk score, how can we calculate a threshold, right? How can we use a threshold to get a binarized value? And to do so, there's many different ways, and it's really highly site dependent. It's even clinician dependent. But one way to do it is to assume that you have some cost for the false negatives and some cost for the false positives. And if you assume that the cost, which is this function for some threshold t, is the same for all groups, then it turns out that there is an exact value for the threshold that we should use for all groups. Okay, and this is assuming that the model is well calibrated, which we just defined, and that is 1 over 1 plus c. So if the false negatives are twice as costly as the false positives, then we should use 0.333 as a threshold. And any other thresholding rule, such as per group thresholding or using a different threshold, incurs higher utility cost. Okay. Now let's use these two new tools to analyze the result that we just saw from the Nature Medicine paper. So again, this is mimic CXR, no finding prediction, and here we've trained 5 different models varying the random seed. So we can plot a AUROC curve, which is a curve over TPR and FPR implicit over the threshold. So in our paper, we used this method of finding the threshold, which is we, for each model, maximize the F1 score. And that corresponds to a threshold of 0.35. So if we plot where the operating threshold is on this curve, we see that indeed, this is where the source of disparity comes from. We see that there is a TPR gap and an FPR gap, as we see in the graph. Now, what about some other metrics? Well, we can look at the AUROC, and we see that surprisingly, the AUROC between the groups are actually not significantly different. And the calibration is also very good for these models. Okay, so is this just a problem with the thresholding? And again, we do observe the large gaps in FNR and FPR, as we saw in the graph a couple of slides ago. And there's a mention that this example is just for these 2 groups. For illustrative purposes, this could also be done for any other combinations of groups with enough samples. What if we try a different policy? Let's try to have a different threshold for each group. This is very problematic, and we'll get to why in a second, but does this work? Well, it turns out that it does. So I just played around with the numbers for a bit, and it turns out that you can quite easily find a threshold for each group that achieves basically 0 gap in underdiagnosis and overdiagnosis, FNR, TPR. And again, these 2 metrics are the same because they are metrics on the risk score. Okay, so we've seen that we can easily achieve equal odds which is equal TPR and equal FPR, essentially by trying to find thresholds that correspond to intersections of the ROC curve. But what are some problems with this? Well, first, if you're paying attention 3 slides ago, we just saw that a threshold is a function of the false positive and false negative costs, right? And so if you deploy one model for one group at 0.5 threshold, this means that false negatives and false positives are equal cost. Whereas if you use 0.63 as a threshold, this means that false positives has almost twice the cost of false negatives. So this is a very significant source of bias, right? This is implicit form of bias that we cannot have in our model. So this is one reason why it's bad. Second is you need to know the group identity. And for something like race or ethnicity, this is especially iffy because people can identify with different ethnicities. And in MIMIC, especially, people can have different ethnicities between different admissions. And this is something that we do observe. And also, people may not be willing or able to give their identity during their ethnicity during admission. And so this is really, really problematic. And finally, this is more of a technical point, but the idea is that when the ROC curves don't intersect for 2 groups, you need to basically make one of the groups systematically worse through randomization. And this is kind of weird because you're just making a group's predictions worse for no reason. Okay, so we've seen that we can use per thresholding to get equal TPR and equal FPR to get equalized odds, but there's a bunch of issues. So the real question is, can we use algorithmic approaches in all these fancy papers at these ML conferences to achieve equalized odds without miscalibration? And surprisingly, the answer is no, with a big asterisk. And the asterisk is that instead of using the binarized equal odds, which we saw at the beginning of the talk, we're using a probabilistic definition of equal odds, which we'll define in a second. So let's consider the following 3 properties. So the first is that each group is well calibrated. The second is that for each group, for the negative labels, we have the same average value of the risk score prediction. Okay, so this is what's known as probabilistic equal odds. It's sort of probabilistic generalization of the binarized equal odds. And similarly, for the positively labeled samples, we have the same average risk score prediction for both groups. Okay, now we use a theorem from the prior work originally proposed in this paper and refined in this paper, which shows that basically, if a risk score simultaneously satisfies these 3 properties, it must be either a perfect predictor, that is a predictor with 100% accuracy, or the 2 groups have different base rates, or have the same base rate rather. So given that we observe different base rates in no finding prediction between the 2 groups, and our predictor is definitely not perfect, it's impossible to have a predictor that achieves these 3 properties at once. And this is from the theory. There's a mathematical proof for this in this paper. Okay, so this is quite surprising because it shows that equalized odds is at odds with calibration, right? And in fact, in this paper, there are a bound, which shows that as you increase calibration, as you improve calibration, you distinctly make fairness worse. Okay, so maybe you don't buy this theorem, maybe it's just boring math. Can we try to do this empirically? So this is what we do in our paper published at CHO this year. And so essentially, we have 3 methods which try to achieve equalized odds. Okay, and the math is that we add on a term to the loss function, which corresponds to some distance metric between the risk score distribution for a group and the marginal distribution. And here, the distance metric is either MMD, or the mean of these distributions, or the predictability of an adversary to predict the group condition on the label. Okay, and we can vary this value lambda, which is how much we want to enforce how strongly we want to add on that additional term, right? So the takeaway here is that as we increase lambda, AUROC of all groups get worse. No groups ever get there, right? All the AUROCs go down. Calibration gets worse, as we'd expect from the previous theorem. We do achieve fairness, both in terms of the actual equalized odds and probabilistic equalized odds. But again, no group gets better. So group fairness worsens performance for all groups, or at least it does not improve performance for any group. So perhaps this is surprising, and you don't buy this for the second, but there's actually a ton of prior work on this in other fields. So for example, in clinical tabular data, there's been shown, and also for generalized MO, essentially enforcing group fairness, equalized odds, worsens all groups. Okay. So the title of this talk was group fairness helpful or harmful? And my argument is that group fairness is probably not helpful. And here are the reasons why. So first, there are many possibility theorems with group fairness, which you might have seen. For example, it's impossible to have equal TPR, FPR, and precision given different base rates. And so these are the metrics that we want to equalize perhaps, and it's impossible to have any combination, any three of these at once. Okay, we've seen that it's easily achievable through per-group thresholding as a post-hoc fairness post-processing, but it has a bunch of issues which we discussed. And it's incompatible in some sense with per-group calibration, which we would perhaps even want more than equalized odds because of the implicit bias present in a miscalibrated model for each group. Trying to achieve group fairness empirically results in miscalibration and worse performance for all. And finally, group fairness is not Pareto optimal. I will define this in the next slide. Okay, so if group fairness is not the way to go, then what is the way to go? So I'm going to argue that this definition of fairness is a better definition, minimax Pareto fairness. So what is minimax Pareto fairness? Well, first, let's define the word Pareto. So what does it mean for a model to be Pareto optimal? So the idea is that we train a grid of models. Let's say we vary hyperparameter architecture, we vary learning rate, and maybe even the loss function, and we plot the loss of group 1 and the loss of group 2, right, in this plot. We say a model is Pareto optimal if you cannot improve its performance without making another, for one group without making another group worse. Right, again, we cannot improve performance for one group without making another group worse. So we're leaving no extra performance on the table. And so here the models shown in green are Pareto optimal and the ones shown in red are not. Okay. And min-max Pareto fairness says we select out of all the Pareto optimal models, the one that has the lowest worst group loss. Okay, so the minimum maximum loss. So here 0.2 is that value, and so we select this model. Okay. The other thing to note is that, as I mentioned before, group fairness is not Pareto optimal. And so here the group fair model is the one that has an equal loss for both groups, and we see that's this model right here. So we can strictly improve upon the performance of the group fair model by having lower loss for group 2. So we're leaving performance on the table by enforcing group fairness, right? And we can always convert a Pareto optimal model into a group fair model just by making predictions worse arbitrarily, but it's very hard to go the other way. So the thing to note is that this is a relative definition of fairness because it's impossible to know what the actual value of the minimum is, and it's also very hard to know whether their model is Pareto optimal. And so we really say that a model is fairer than another in this definition if it has a lower value of the worst case loss. And finally, this is highly non-trivial to achieve. Generally requires reweighting and retraining, not just a thresholding thing like we saw previously with group fairness. Okay, so the question is, can we achieve min-max Pareto fairness, or here just min-max fairness with existing computational methods? So here we benchmark the performance of some baseline methods, ERM, where we train a model on all the groups, balanced ERM, where we balance the groups by their population size, compared with 3 methods, which try to maximize performance of the worst case group. Okay, and these are the 3 methods shown here. And somewhat surprisingly, we find that none of these 3 fancy methods, which dynamically upweight samples during training, outperform simple baselines. And the simple baseline here is data balancing. So here we have the performance metrics for different attributes. And here the axis is the difference between a model's performance and balanced ERM. So we see, for example, in EROC, that no model significantly goes above the 0.0 bar. So the conclusion is that minimax Pareto fairness might be a good definition, but it seems that ERM is already achieving that definition fairly well. This has also been shown in a couple other settings in tabular data and generalized machine learning. Okay, so let's take a step back. Let's think about the data that we're using for our method, right? Why do we observe disparities between men and women, between ethnicities, between age groups, and so on and so forth? What are some sources of disparity that might exist within the data, right, upstream of the ML model? So here I will focus on one source of bias called label bias. And I will define label bias as when we have observed labels that differ from the ground truth at different rates for different groups. So you can imagine this as having more corruption in the label for one group than another, worse label quality. Okay. So in order to have label bias, we have to have mislabeling, right? If everything is perfectly labeled, then there's no label bias. So the question is there any mislabeling in X-rays? Yes, absolutely there is. So how do we actually get the labels that we use for the X-rays? Where do they come from? Well, first, we have some images taken from a study, right? We have the radiologist, which looks at the images and writes down a note. And then we have the labels that we use, which come from a NLP-based labeler. So this is called the Checkspert labeler, which is used in Mimic CXR and Checkspert. It's a rules-based NLP labeler that pulls out these labels from the notes. So there's sort of two different potential places where you would have mislabeling. The first is the radiologist does not mention enough content in the notes from the image. And prior work has studied this, and they found that the radiologist looking at the image and the radiologist looking at the note to identify labels only has a 0.4 correlation or agreement by this kappa coefficient. So this is very poor, right? We're already losing a ton of information going from image to notes. What about going from notes to labels? Well, prior work, there's a couple prior work that has a couple numbers, but really the average F1 score in your Checkspert labeler is about 50%. Okay, so we're losing tons of information again going from notes to labels. We're losing information going from study to note. There's a crazy amount of mislabeling in X-rays. Okay, so the question is, there's all this mislabeling, but does it differ between groups? And so here we study in particular this edge going from the note to the label. We got a radiologist to label about 1,000 images from Mimic CXR, and these are images which the labeler defines as no finding. Okay, and here we ask between intersections of groups, for example, white males, what percent of the image is actually no finding, right? So we see that, and there's a bigger version with CIs in our paper, but essentially, overall, the performance is very poor. So the performance average is like 64% accuracy. Really, the labels are just garbage. And we do see that, particularly within different age groups, you get much worse label quality in older populations, right? In older populations, you have like 40% accuracy in your label. So this might account for some of the observed gaps that we observe, for example, in differences in ERC between age populations. And this is just really a preliminary study. We need probably a larger scale study across different labels and other sources of bias to get a definitive conclusion on what the source of the bias is. I think that'd be a good area of future work. But the summary here is that label bias may be a responsible factor for differences in disparities, differences in performance that we observe between protected groups. Okay, so to conclude, I'll provide some practical guidance for clinical fairness. First, evaluate comprehensively. So we've seen that calibration error is really important, and it's really underutilized in the fairness clinical setting. And so I think it's good to evaluate a wide variety of threshold-free, threshold metrics, calibration error, evaluate on the worst case group, the average performance, the gaps, etc. Second, where possible, consider sources of bias in the data process, upstream of your ML model, right? Take steps to correct those whenever possible, such as by getting a better labeler instead of using one that has 50% F1 score. And the third, not all gaps need to be corrected. So the important thing is you have to have some clinical knowledge to determine whether a gap is clinically justified. In the case of age, for example, maybe the task is harder for older populations. You have more comorbidities, X-ray is more noisy or something. You would expect to have lower ERC flows populations. Correcting those gaps will just lead to worse performance for everyone. You're not going to get a better model by correcting the gaps. Finally, I'll conclude by saying that algorithmic approaches alone are probably insufficient to ensure that the use of ML in healthcare is equitable. You would really need sort of better data collection. You need a lot of clinical and domain expertise in order to make sure that we have equitable ML for healthcare. Thank you for listening, and I'll take any questions that you may have.
And thank you for speaking. That was amazing. Lots of great information in there. It's really exciting to see, theory results appear and then validation of that theory. So thank you for speaking about it. I would invite the Zoom audience to put their questions in the chat. But I know that we already have one, so I'll try and summarize it here, or maybe I'll just read it out to you.
Sure.
So this is a combination question from initially Mehan Neurojan, and then it was added onto by Ben Glocker. And essentially, we know that that the mimic CXR is highly biased and it has confounding biasing factors, so that there are age differences and sex differences, and those are entangled in the protected demographic. So that not only do we want to be fair across age differences, but across ethnicity differences, those factors are entangled, and those are entangled with disease factors. Would we believe that if we did not have those large entangling factors, or alternatively, if we had a huge data set, right? If we observed everything, would the changes in thresholding, would changing in thresholding still produce these same biases or problems?
Yeah, that's a good question. So I think, first of all, the issue, I believe, is not of sample size. So I think the issue with having different operating points at the same threshold is just due to the implicit incompatibility between the fairness definitions. Coming back to the point about being able to identify group labels from the data, I think that's a really interesting problem. Essentially, I've seen some discussion about this in chat as well. It's shortcut learning, right? Is what they call in the literature, or spurious correlations. And we've seen that in prior papers. You can identify race from X-rays with high accuracy, which is quite surprising. So the question is, is that a result how does that result fit into here, right? And I think maybe being able to identify race is surprising from a radiology perspective, but it's not surprising from a ML perspective, because if you were not able to identify race from the X-ray, you would have demographic parity, right? Y hat independent of G for the racial groups, which is bad because we do not want this definition of fairness, and it's also not what we observe. So I think having demographic information in the data is not necessarily bad, as long as it can lead us to a better definition of fairness, if that makes sense.
Yeah, I mean, that made sense to me at least. But I guess to add on to that, in an earlier comment, you were saying, well, if we have different thresholds, this implies different false positive, false negative costs.
Right.
But could it alternatively imply that we simply have different false negative, false positive rates, right? And that these curves are different for different demographic groups, so that we are forced to choose different thresholds?
So I think implicitly having a different threshold just means you have different false negative and false positive costs. But there's a lot of literature about this in the field of like Bayesian decision theory that I'm not too familiar with. But there is a prior work that looks at this from a utility perspective, which is this paper, which is quite good. So I recommend checking that out.
Okay, and then we have an add-on. So first, could data level approaches to improving fairness help improve performance for subgroups? For example, using data augmentation techniques, either simple transforms, etc., or copy paste, but changing demographics, assuming to improve representation across groups in the data set. So basically, do you believe that augmentation techniques could be used here as some form of proxy across to do resampling, right?
Yeah, I think that's a good point, and I think it's absolutely possible. So you can think about the data augmentations, game-based data augmentations, as kind of an upstream, as a weaker version of upstream data collection, where you're getting more data, but it's generated from a model. And if you do so in a fairness-aware way, I think it's simply possible that those methods can improve the fairness or worst case performance of a model.
Okay, we are well into our coffee time, and as you can tell, the sun is shining in my office, so I'm blinded and I can't see anything. But once again, thank you for speaking, Haoran Zhang, and
Thank you for having me.
And he'll be around in the chat if you want to ask him further questions. We have reopened the polls. Good morning to everyone on American or North American continent time, also South American continent. And so, yeah, we'll be taking a 10-minute break. We're going to open up a breakout room so that people can unmute themselves and have a talk in there if they want to talk, but they don't have to speak to all 100 participants. So yes, thank you again, Haoran, and we'll be taking a 10-minute break at this point.